Great, thanks very much for that fantastic first session. So I'd like to ask our speakers for this session to come up onto the stage and keep us company. Thanks very much. So good morning and welcome to the tuberculosis session with my co-host Mark. I'm Kathy Hewison. This session is exciting. It's going to address a lot of the issues that we see in the field in relation to tuberculosis, difficulties in diagnosing TB in children, difficult resistant forms of TB, and chronic disease after tuberculosis. The first presentation is going to address the diagnosis of TB in children and some of the challenges. You might not be aware that 50% of children with tuberculosis are never diagnosed, and 96% of children with TB who die without ever being started on treatment. So this underdiagnosis is very much related to the lack of good tools we have to diagnose TB in children. Children have tuberculosis with very few bacteria, and therefore the tests that we have don't work very well. Clinicians need to use their skills and diagnose most children with TB clinically. So in 2022, WHO did make a set of new recommendations which we saw at MSF as an opportunity to start to address the problems of managing TB in this very vulnerable population. These recommendations include treatment decision algorithms, which are to help clinicians address these problems of underdiagnosis of TB in children. So we created the project that's called TACTIC, Test, Avoid, Cure TB in Children. And this project has three big pillars. The first pillars are implementation, implementing these WHO recommendations on diagnosis, management, and prevention of TB in children. The second pillar is advocacy. Advocacy for better tests, better tools to help us manage TB in children, but also advocacy to implement these recommendations. And the third big figure is operational research. How do these recommendations work in the field? Do we diagnose more children with these treatment decision algorithms? Are they acceptable and feasible in our settings? So I'd like to introduce the first two speakers. Helena Huerga will join us by distance. I hope you're there, Helena. Helena is a very experienced epidemiologist and medical doctor. She's very experienced in infectious diseases epidemiology, particularly in tuberculosis, and specifically a well-known expert in the field of diagnostics. Emily Briskin is an epidemiologist specialised in humanitarian studies, and Emily has a big job on this study. She's it's a 5-country study. She's the multi-country study coordinator. Okay, so let's go ahead. Over to you, Helena. Are you going
Good morning.
to... Oh, right, yeah.
In 2022, WHO published new guidelines that included a new interim conditional recommendation on the use of treatment decision algorithms for tuberculosis in children. As these new recommendations were interim and conditional, WHO also called for generations of evidence through research studies to externally validate the new treatment decision algorithms and inform a future review of the recommendation. The TBalgoPed is a multi-country study to assess these new treatment decision algorithms for tuberculosis in children. The primary objectives of this study are to assess the diagnostic accuracy and the diagnostic cascade of the new treatment decision algorithms for tuberculosis in children, and to assess the feasibility and acceptability of implementing these new algorithms. The study has also some secondary objectives, and today we are presenting TB case notification rates prior to and following the introduction of these algorithms. Here are the two treatment decision algorithms for children less than 10 years of age with symptoms suggestive of pulmonary tuberculosis. Algorithm A is for contexts with access to chest X-ray, and algorithm B is the same but for contexts without access to chest X-ray. If we now focus on the first part of the algorithm, it's the same for algorithm A and B. The algorithm first identifies children with a high risk of disease progression. These are children less than 2 years of age living with HIV or with severe acute malnutrition, and these children should be investigated immediately for tuberculosis. If the child does not meet these conditions, then it can be treated for the most likely non-TB conditions and in follow-up in 1 or 2 weeks. The algorithm includes GeneXpert and TB-LAM when available, and also the history of a contact with a person with TB. Then the second part of the algorithm is a score that is based on signs and symptoms of tuberculosis and on the findings of the chest X-ray for algorithm A, and on signs and symptoms of tuberculosis only for algorithm B. If the sum of this score is more than 10, the algorithm recommends to treat for TB, and if not, to review the patient in 1 or 2 weeks. The TBalgoPed study is a multi-country study with 3 components: a prospective diagnostic study, an analysis of routine program data, and a mixed method study. For the first 2 components of the study, the population are children under 10 years of age with signs or symptoms of tuberculosis. And for the third component, the mixed method study, the population are health workers, policymakers, program managers, key informants, and caregivers. We have conducted this study in 5 countries: Nigeria, Niger, Guinea, Uganda, and South Sudan. Let's start by the prospective diagnostic study. The procedures of this study follows the algorithm that I have just presented. So first, a medical history and a clinical exam, then a GeneXpert and a TB-LAM when these tools are available, a chest X-ray if the chest X-ray is available, and then the score based on clinical and radiological signs. Then, if indicated, there is a follow-up visit at 7 to 14 days. And as part of the study for all children, we had a follow-up visit at 2 months systematically. This slide shows the characteristics of the population. We included 1,613 children. And you can see in the first column that the median age was 1.7. 72% of the children were severely malnourished and 10% were living with HIV. If we now look at the other columns, we can see that in each country, we focus on specific populations. For example, in Guinea, we focus on children living with HIV and all were ambulatory. Nigeria, and South Sudan included mainly children hospitalized and mostly severely malnourished. And Uganda, it was most a mixed population with both hospitalized and ambulatory, 22% severely malnourished and 6% living with HIV. Among all children included in the study that were children with symptoms and signs of tuberculosis, 27% were diagnosed with TB and treated and started on TB treatment. And you can see in the graph on the right that most of these children were started on TB treatment at the initial assessment within 1 week. Now let's look at the reasons, the main reason to start TB treatment, to diagnose the children among those that were diagnosed with tuberculosis, so 498 children. If we follow the algorithm steps, starting by GeneXpert and LAM, we can see that among these children, 7% were XPER positive and 6% were LAM positive. For 19% of the children, the main reason to start TB treatment was the contact with a person with TB. And for 70% of the children, the main reason to start TB treatment was the clinical and radiological score. We also look at the diagnostic accuracy of the new algorithms, and these are interim results and part of the population, 1,354 children. We assess the sensitivity and specificity of the new algorithms versus a reference standard that was based on the international consensus case definitions for intrathoracic TB in children, and we found that the sensitivity was 91% and the specificity 87%. And now Emily will continue with the rest of the presentation. Thank you very much.
I can just continue as the slides are loading. So as Helena mentioned, the second pillar of our study was an analysis of routinely collected data. And to do this, we took data looking at the health facility registers and the TB registers in each of the sites. And from these, we extracted the number of admissions or consultations that were conducted in each site, as well as the number of children who were put onto TB treatment. And so for this part, we can go back one slide. So we looked at the number of children who were initiated on TB treatment, and we looked at this for a period of about 1 year before and 1 year after the algorithms were implemented in each site. And then we took this data and we conducted a multivariate interrupted time series analysis. And this analysis model was adjusted for several factors, including whether or not the algorithm had been introduced yet. It was also adjusted for things like whether or not it was peak malnutrition season, the time since the algorithm had been introduced, and it was also adjusted by country site. And the results of this analysis are shown here. And we can see that each dot on the slides represents the proportion of children that were admitted or consulted who were initiated on TB treatment. And the unshaded area on the left of the slide is before the algorithms were introduced, and the shaded area on the right of the slide is after the algorithms were introduced. And we can see that in general, across each of the sites, the proportion of admitted or consulted children initiated on TB treatment tended to increase after the algorithms were introduced, which is what we would expect. And this is further illustrated through the blue lines on each graph, which were generated through the model. And the model results also further reinforce this trend, as we found that on average across the study sites, the proportion of admitted or consulted children initiated on TB treatment more than doubled after the algorithms were introduced, with an effect size of 2.23, and this was statistically significant. The third pillar of our study was the feasibility and acceptability study, which we conducted using a mixed methods approach. This included focus group discussions with healthcare workers, as well as semi-structured interviews with key informants, caregivers, and healthcare workers. And these discussions were then analyzed thematically and through critical discourse analysis. And for our presentation today, we'll focus mainly on the results of the discussions with the healthcare workers. In discussing with the healthcare workers around their experience using the algorithm, we found several positive results around their experience. The healthcare workers shared that using the algorithms in general helped them to speed up their processes and increase their TB diagnosis. The healthcare workers also felt that using the algorithms helped to increase their autonomy, especially in healthcare centers that had few resources. The healthcare workers often noted that using the algorithm helped to enhance their professional skills, and this was often associated with the training that accompanied the introduction of the algorithms. And overall, healthcare workers found that using the algorithms was efficient, the algorithms were easy to use by all types of staff, and the algorithms were helpful and accessible and acceptable. And we can illustrate this with a small quotation from a healthcare worker in Uganda who shared, "I feel there are some advantages in the way that it, the algorithm, will guide the clinician who is going to diagnose, to make a rational diagnosis." And of course, as with almost any intervention that you could introduce into a healthcare setting, there were some small challenges that were identified. So some healthcare workers identified that they felt that when using the algorithms, they felt their workload increased, and this was often tied to the idea that when using the algorithms, they felt their consultations took longer. The healthcare workers also identified that it was very important to have a high quality of communication with the caregivers when using the algorithm. And this makes sense, because as Helena explained when introducing the algorithm, it's important to know when using the algorithm whether or not the child has a history of contact of someone in their household living with tuberculosis. And it's also very important to know the exact number of days that the child has been dealing with each symptom in order to calculate the symptom score. So of course, in order to get this detailed level of information, it makes sense that the healthcare worker would need to gain some trust and spend some time discussing with the caregiver. And we have a small snippet of a discussion of healthcare workers in Niger to help illustrate this point. These healthcare workers share, because when you ask a mother about the big cough, she doesn't even know what it is. She doesn't even know what it is. Tuberculosis, yes. And secondly, she thinks she'll be stigmatized. Even if she knows there's someone who is suffering and is being treated at home, she's not going to tell you that easily. So, from the results of these three pillars of our study, the diagnostic accuracy study, the analysis of routine data, and the feasibility and acceptability mixed method study, we have a few conclusions we'd like to share with you today. First, we found that the diagnostic accuracy of the algorithms was high, and most children who were diagnosed with the algorithms were diagnosed at their first assessment. We also saw that the clinical and clinical radiological scores were very useful elements of the algorithm for diagnosing TB. We found on average a twofold increase in TB treatment initiation across sites after the algorithms were introduced, and we found the algorithms were well accepted by health workers. They provided autonomy and facilitated TB diagnosis in children, particularly in health facilities with less skilled staff and those offering ambulatory care. We're very pleased to share with you that so far we've seen the study implementation and results are already helping to support the algorithm used by MSF and ministries of health in the study sites, as well as in other sites in countries around the world. We have found that the feasibility and acceptability results can assist in tailoring site-specific implementation. And we've also found that as the algorithms are introduced and more children are put on TB treatment, it's very important that the corresponding TB drugs are planned for from the beginning. We hope that the evidence generated from this study will inform the WHO review of guidelines planned for 2026. And we also anticipate further research on specific aspects of using the algorithms, such as in children living with HIV and in settings with a high prevalence of malnutrition. This work would not have been possible without the study participants, our entire research team, and our partners. Thank you.
Thank you very much, both presenters. I would like to introduce you now to Lorenzo Guglielmetti. Sorry for my Italian pronunciation, Lorenzo. Lorenzo is co-principal investigator of the endTB and endTB-Q trials, and he's currently also the chair of the study group on mycobacteria of the ISCMIT and clinical trial chair of TBNet. Maybe most of you, or at least people from my age, may remember that DRTB treatment was a long journey with very toxic drugs. And I think also once we piled up all the treatments to a height that came even higher than the Eiffel Tower. And I think also this was something quite frightening for patients to remember. 2 years of treatment was a difficult journey. Nowadays, we have new protocols that have been developed. The practical study came out, the endTB-Q trial as a follow-up of the endTB trial propose now novel treatments and also much shorter treatments with much less toxic toxic side effects. Lorenzo will lead us through the meanders of this endTB-Q trial, which looks at developing a short course treatment for pre-XDR-TB, which is the tuberculosis resistant to rifampicin and also fluoroquinolones. He will explain us the nuances of what means non-inferiority and how important it is to stratify our population of patients in order to provide the best treatment to these patients. Lorenzo, the floor is yours.
Thank you very much. The challenge. It's a pleasure, and it's my last presentation of the director of the endTB project, which was a long-standing collaboration between MSF and other major NGOs such as PIH, IRD, and all the other partners that you can see here. But it's definitely not the last time you will hear about the endTB project because there is so much more left to do. First of all, let me start by thanking all the trial participants, more than 300 participants. We had more than 1,000 patients across many countries that accepted to be screened for the study, and the hundreds of people who worked in the operational team, and a few of the more faithful are here today. I want to thank Mathilde, Mylène, Marava, Audrey, and Laura. And now a few words about the trial design, first of all. So this endTB-Q is a randomized, controlled phase 3 trial looking at patients with pulmonary tuberculosis with pre-XDR-TB, which is pre-extensively drug-resistant TB. We defined as the resistance to both the most effective first and second line drugs, namely rifampicin and fluoroquinolones. And we included adults and adolescents of 15 years of age or more. In this trial, we compared a stratified duration strategy of 6 to 9 months. We will see more about that later, using a regimen including 4 drugs: bedaquiline, delamanid, linezolid, and clofazimine. We will refer to that as BDLC in the presentation, to a standard of care control, which was the individualized long regimen of 18 months of duration. And the design, as Mark mentioned, was non-inferiority, meaning that we wanted to show that the intervention is as a similar or at least not worse efficacy than the comparator, because the advantage would rely mostly in the reduction of 50 to 60%, 63% on the treatment duration, and expected reduction also of the adverse events. So the stratified duration strategy was assessed looking at baseline characteristics of study participants. We looked at the chest X-ray, if there was a presence of any lung cavity, and also at the highest smear grade in the semi-quantitative evaluation of the sputum taken at baseline. And combining these two variables, we will define the extent of disease as extensive or limited. And after that, patients with extensive disease would receive 9 months of treatment, while patients with limited disease would receive 6 months, unless they had a delayed treatment response, which we assessed by looking at sputum culture while on treatment. In that case, we would prolong also patients with limited disease to 9 months. So now coming to the results of the endTB-Q trial, we first of all achieved to enroll the targeted sample size of 323 participants across 10 sites in 6 countries. And as you can see, 80% of participants were included in countries with very high prevalence of pre-XDR-TB, such as India and Pakistan. Out of the 323 randomized participants, we included in the safety population 318 who actually started treatment, and then 247 in one of the co-primary analysis population, the modified intention to treat on MITT, which included participants who had a positive culture at baseline, confirmed fluoroquinone resistance, and no resistance to the drugs in the experimental regimen. And 233 participants included in the per protocol or PP, the other co-primary efficacy analysis population, where we included MITT participants who also followed a protocol adherent course of treatment. Now, having a look at the baseline characteristics in the MITT population, I would like to draw your attention on, first of all, the 7.3% of participants were minor, so adolescents of 15 to 18 years of age. We had a low overall prevalence of co-infections with HIV and other viral hepatitis, as you can see, high rates of diabetes, and overall 2/3 of participants had extensive disease based on the presence of cavitation and the positivity of the sputum smear at baseline. So now looking at the control arm, in particular, this is important to draw your attention on, but first of all, on the duration, which was 18 months for most participants, as expected. In terms of the composition of the control arm, this was very similar to the experimental arm, with over 90% of study participants who actually received the same regimen, BDLC, plus 1 or more drugs. So a very similar but fortified regimen and given for a longer period. Now coming to the primary endpoint on the efficacy results, which is the proportion of favorable outcomes at 73 weeks post-randomization in the MITT population. You can see here the results, and overall we had excellent results in both arms, with more than 86% of treatment success in both the experimental and the control. We were very happy to see that the results in the control were really amazing. However, they actually outperformed the experimental arm, which was not expected, of course. And so looking at the unfavorable outcomes to try to understand the reason for this difference, you can see here there is actually no difference in mortality rates, in poor treatment response, and also in permanent discontinuation due to adverse events. So the main difference comes from these two outcomes here. So first of all, recurrence rates. We had 5% of recurrence in the experimental arm, while there were no recurrences in the control. And we had more loss to follow-up and constant withdrawn in the control than in the experimental arm. This was expected, and actually these rates are lower than what we were imagining. So this all leads to our primary comparison between the experimental arm BDLC minus the control, compared in the forest plots. Here you have above the MITT and below the per protocol, the two co-primary analysis populations. You have the point estimate of the difference in the adjusted analysis here, and the 95% confidence intervals for both comparisons. And this is the pre-specified non-inferiority margin of -12, and as you can see, in the MITT, non-inferiority was the lower bound of the non-inferiority interval does not cross the -12, while this is crossed in the per protocol population. So in conclusion, we cannot conclude for non-inferiority of the experimental strategy to the control. And to try to understand a little bit better why we came to this conclusion, we performed a pre-specified analysis stratifying by extent of disease extent of disease at baseline, were defined as we have seen before. And here you can see that although there is no statistically significant difference, there is a trend towards better outcomes in the experimental than in the control, in the limited disease group, while in the extensive group we have a trend in the opposite direction. And the last element of our analysis of the efficacy results is looking at recurrences. So this is a Kaplan-Meier curve showing time to recurrence after the end of treatment in each arm, which is stratified by arm and by baseline disease extent. You can see, first of all, in green, here below, you have the control arm where there were no recurrences. It's important to note that the follow-up time in the control arm was around 6 months, so much smaller than in the experimental regimen, where the follow-up was much longer, over almost 1.5 years. And you can see the difference between patients in the experimental arm who had limited disease at baseline, where we had only 1 recurrence, and those with extensive disease, where we had 8 recurrences. So all these 9 recurrences were actually confirmed to be relapse by whole genome sequencing, meaning that the strain who recurred was actually the same strain that was present at the beginning, isolated at the beginning from the same patient. And in 7 out of 9 of these confirmed relapses, we found acquired drug resistance, mostly to bedaquiline and clofazimine. Now, a few words about safety, really quick. So if you look at the primary safety endpoints, we had the overall rate of any grade 3 or higher adverse event, any serious adverse event, and any drug which was permanently stopped due to adverse events. And in all these comparisons, you can see that we have a higher proportion of adverse events, events in the control rather than in the experimental regimen, which is expected because of the different duration, of course. And if you look at the adverse events of special interest, which were the ones related specifically or expected to be related specifically to the drugs used in the experimental regimen, we had high rates of these two first adverse events, which are usually related to linezolid use, myelosuppression, and peripheral neuropathy, and they were both more frequent in the control than in the experimental arm, which once again was expected because linezolid use was prolonged in the control arm, and also in the experimental regimen we had a structured dose reduction after 4 months. While the 3 other adverse events of special interest, hepatotoxicity, optic neuritis, and QT prolongation, were actually not very relevant in our study. Which leads us to the final conclusions of the trial. So first of all, we found that the experimental regimen of 6 to 9 months of BDLC for pre-XDR-TB patients had a high cure rate of 87%, so very good results. However, these rates were actually slightly lower than the long control regimen, and therefore non-inferiority was not established. In patients with limited disease as baseline, as we have defined them, the 6-9 BDLC regimen showed excellent results, and actually we think that this regimen could be preferable to the control in this population due to much shorter duration, lower pill burden, and better tolerability. In people with extensive TB disease at baseline, however, even 9 months of BDLC were not sufficient to prevent relapses, and therefore a long and fortified regimen may be recommended. However, probably what we would recommend is really to have a discussion with each patient to explain the pros and cons of each option. So fluoroquinolones are a key drug. We knew that before, and now it's confirmed even more, and that also confirms that the fluoroquinolone testing is essential for every patient with rifampicin-resistant TB. This is very important also because other recommended regimens by the WHO for pre-XDR-TB show similar issues as the BDLC regimen, namely they have similar relapse rates and also risk of acquired drug resistance. We also think that specifically designed trials like endTB-Q with an internal control and sufficient time to detect relapses are optimal and needed to identify and improve further the treatment for pre-XDR-TB. And finally, unfortunately, there are still major access challenges to the BDLC regimen due to the cost and access to drugs, diagnostics, etc. So while concluding, I want to thank again all the participants and all the teams that helped performing this long study, all our partners, the funding, the main funder, which was United, but also really want to thank MSF, who came in and really saved the trial and allowed us to perform it as planned, and Mark knows something about that. And with that, I thank you very much.
Et maintenant, j'ai le plaisir d'inviter Dr.
And now
Gino
I have the
Agbota,
pleasure to invite
qui est
Dr.
médecin
Gino
épidémiologiste,
Agbota,
directeur
who
de
is
recherche clinique
a medical doctor,
et titulaire de
epidemiologist, and
maîtrise en
clinical
santé
research
publique et d'un
manager
doctorat en
with an
épidémiologie.
MPH,
Il
MSc
possède une
in
vaste
international
expérience en
public
recherche
health and a
clinique,
PhD in
particulièrement
epidemiology,
dans les maladies
with extensive
infectieuses,
expertise in
émergentes et
clinical
réémergentes.
interventional,
Il a également acquis
epidemiological,
d'importantes
and
compétences en
operational
matière
research, in
d'analyse,
particular
d'interprétation,
infectious
de
diseases
synthèse,
and
mais aussi de
re-emerging diseases,
modélisation
also
adaptive.
with an important
Il va
analytical
lever le voile
interpretation
sur
and skills,
la vie des
including the
patients
management
après
of
un
important
traitement
and
de
complex
tuberculose.
epidemiological data.
Effectivement, trop
He's
souvent,
going
nous
to shed
regardons
some
nos
light
statistiques
on the life
et nous
of
sommes
our
satisfaits
patients
avec
after
le nombre
treatment.
d'abandons, le nombre
Now,
de
we
personnes
may deem
traitées.
ourselves satisfied
Mais
with the number of lost to follow-ups or
si
number of
nous
people
regardons
we could
ce qu'est
treat.
la vie
However,
après un traitement,
let's
ce que
take a
deviennent nos
look at
patients, eh bien, donc
what
effectivement,
life looks
on n'a pas
like
vraiment
for
beaucoup
our
d'idées, sauf
patients
que
after
Dr. Gino
treatment.
va nous dévoiler
And thanks to
effectivement ce qu'il a
Dr.
découvert
Agbota,
dans
we are
plusieurs
going
pays en
to
Afrique, de l'Ouest.
get a glimpse of
Dr.
what
Gino,
is the fate
j'ai
of
hâte
these
de vous faire
patients
dévoiler le
in
fruit de
several
votre
West
recherche.
African countries.
Merci.
So we are looking forward to his
Je
presentation.
vais vous présenter le
Hello everyone.
post-TBC.
So I'm going to tell you about the post-TB-Seq project on medium and long-term post-TB sequelae in
La
sub-Saharan
tuberculose est une
Africa.
maladie infectieuse qui touche principalement.
TB is an infectious disease affecting the lungs. As we all know, however, every year WHO estimates that there are 10.8 million new cases of TB, more than 1 million people dying from TB. 25% of cases of these cases are reported in Africa, or were in 2023, and this affects mainly the young adults in developing countries, people between 25 to 45 years of age. Now, these are chest x-rays of 2 patients who have completed treatment and considered to be cured according to WHO's guidelines, recommendations. You can see that both lungs are normal here at the top. Probably someone who benefited from early diagnosis and treatment. However, in the second patient, just 1 lung is still functional after treatment. It's probably someone who was diagnosed late with an immune response, host pathogen interaction with excessive inflammatory response. And this led to lesions and damages, important lung lesions, and post-TB sequelae. So it means that even if you treat someone successfully, it doesn't mean that the patient can recover completely and these patients may present with post-TB sequelae. And this gives me a cue to give you an introduction on post-TB lung disease, PTLD, as they are called, these diseases, and their impact on quality of life. One patient in 50 worldwide has been treated for TB, on top of which you should consider that some 50% of people treated for TB will present with or develop sequelae, and with chronic diseases, acute infection, and of course this does impact their quality of life. So this acute infection has become a chronic disease in many parts of the world. There are very few prospective data on PTLD, especially in Africa. And as far as we know, there's no data on the medium and long-term PTLD burden and their impact on quality of life. Now, the post-TB-Sick project, of which I'm one of the main sponsors, aims at estimating the medium long-term burden of PTLD after the end of TB treatment. We also want to study the association between the presence of PTLD and the poor health-related quality of life in the medium and long term in people who have been treated for TB in sub-Saharan Africa, to identify factors associated with PTLD after TB treatment. Also describe the care pathway, and also evaluate the impact of pulmonary rehabilitation program in terms of improving respiratory function and also improving quality of life. I'm going to show you results in link with the three first objectives. In order to meet these objectives, we do have a cohort based on former clinical trials that were conducted in Africa some years ago, some 20 years ago. And in those clinical trials, the TB patients clinically confirmed in the laboratory were treated like Ofloturb, Rafa, Rifavirenz, Rifashon, and they were conducted mainly in Uganda, Benin, and Guinea. And we wanted to look for these patients, to call them, and perform a thorough assessment, a clinical assessment, also lung assessment, to look for PTLD. Once we had located those patients and their informed consent obtained, they were subjected to a clinical examination. We looked for their history, medical history over the past 20 years. We also assessed their respiratory function with spirometry, 6-minute walking test, chest X-rays, CT scan for some of them, depending on the criteria. Quality of life was assessed with 2 standardized questionnaires I mentioned later. Now, let's review the definitions. PTLD, in our definition, is the presence of pulmonary functional impairment on spirometry data, according to the latest lung function initiative guidelines. So this helps you to identify obstructive or restrictive or mixed ventilatory disorder and or the presence of symptomatic bronchiectasis symptoms confirmed by CT scan. The 2 questionnaires that were used were firstly the St. George's Respiratory Questionnaire, or SGRQ, which is quite specific for respiratory disorders, looking at 3 domains, 3 areas: symptom frequency and severity, also physical activity limitations, and also psychosocial consequences and their impact on quality of life. If you're above 10, well, it means the quality of life is severely impaired. The second one is the SF36. It's more general, and if you are above 62, the quality of life is also considered to be impaired. And also we looked more precisely for the impact on current health and also what sort of impact on the outlook and resistance to illness. Now, let me share with you the preliminary analysis of the results. Following our search, 204 participants could be included out of 322 in Uganda. In Guinea, 360 could be included out of 1,100, and in Benin, 122 out of 528 patients could be included. 30 to 50% of those participants couldn't be contacted. We could not locate them during our inquiry. And noteworthy, the death rate, mortality rate is quite high. As we could see, we could observe during our this preliminary phase, and a lot of these patients were co-infected with HIV and TB. So the mortality rate is quite high for those patients 10 years down the road after treatment. In total, 686 participants could be included in our study. And now let's take a look at the characteristics in the medium and long term of PTLD. 21.5% of individuals were presented with ventilatory disorder, 25% restrictive disorder, 8.2 mixed, 14% bronchiectasis, and so in total, 56% of them with PTLD. And among them, 34% presented with severe decrease of first expiratory FEV in 1 second, so FEV1 under 2.5 Z-score, which is in itself something that makes you eligible for a rehabilitation program. The characteristics, depending on PTLD or lack of PTLD in the participants. Well, let's start with the time to our assessment between end of TB treatment and our assessment. The median time is 11 years. However, the column with more than 10 years corresponds to more than half of the participants. The median age was 43 in all 3 countries. More male patients, 75%. 35% of these participants were co-infected with HIV, and 11% diabetes. Alcohol abuse was reported in 17% of participants. Smoking was significantly associated with PTLD, and 12% of these participants were declared the use of coal, and 57% the household biomass combustion. It's a univariate analysis. In the same chart, quality of life results on SGRQ shows that the median score is much higher in patients with PTLD. The median score is 10, therefore associated with a major impairment and deterioration of quality of life because of PTLD, because of post-TB sequelae, which is not the case, which we could not observe or did identify on the SF36 return. And there is also this link with the presence of post-TB sequelae. Clinically, PTLD participants are more symptomatic versus the other participants, and hemoptysis, in particular coughing, also poor exercise tolerance. In conclusion, despite the limitations or likely limitations in terms of representativity of initial clinical trial population, our study allowed a rapid assessment and a thorough assessment of medium and long-term PTLD burden in this region. We could show that within 2 to 20 years, PTLD is highly common in sub-Saharan Africa, and it's also associated with a severe deterioration of quality of life. There's also high mortality of TB, HIV patients 10 years after treatment, and poor HRQOL more prominent among those with PTLD. The outlooks, we think that we need to reinforce early TB diagnosis. We need also to allow these people to get access to pulmonary rehabilitation programs, is to restore their functional capacity and improve their quality of life, as is already the case for the congestive obstructive bronchopathy. And there's also some need for research on host-directed therapies to better modulate the immune response and to avoid the hyper-responsiveness that leads to the damage of lungs. I'd like to thank all participants and also the study team in Conakry in the 3 countries where we conducted the study.
Merci beaucoup, Gino.
Thank you very much,
Okay,
Gino.
so we'll start with the first questions directed at you, Lorenzo. It's from somebody online. How is endTB helping ensure access to the newer drugs? And this person says that in my country, we still don't have access to Delamanid, even in MSF projects, and protonmanid isn't available for B-Palmer either. Have you got any ideas how to close this gap?
Yeah, thank you for the question. Well, it's unfortunately it's not surprising that you know in your country, I don't know which one it is, but you don't have access to the Delamanid, and protonmanid is still a huge. This is what when I was mentioning about the access issues, there are many, but probably the most striking one is how much we struggle to access some of the key drugs. So the Delamanid has a price which makes it unaffordable in almost all the high burden countries in the world, and even in Europe we have huge, and in North America there are huge access issues, which is really surprising. And in addition to problems in accessing drugs, we have huge issues in accessing drug susceptibility testing. So when we talk about preventing resistance and antimicrobial stewardship, not being able to diagnose resistance is a big problem that we have. So in the endTB project, there was awareness since the beginning that these drugs that were available and became available and made it all possible were going to be challenging to get access to, and also for the diagnostics part which are required to use this regimen. So we try to embed since the beginning an important work in terms of advocacy. We involved the access campaign, worked together with many other organizations, and actually achieved excellent results. If you think that, for example, the price of bedaquiline has been reduced enormously these years, making it affordable. For example, the B-Palm regimen and the endTB regimen without the Delamanid are definitely inside the target price, which was set more than 10 years ago by the access campaign. So that there was a lot done also at each country level to try to increase access and registration to these drugs. But unfortunately, there is much more to do, and I think Mark and Katia also can comment.
Yeah, thanks, and very good question indeed. Now, I will also jump in here with my current role as Access Regional Coordinator in MSF for Europe and the Middle East. But as a matter of fact, so MSF movement has decided to keep as well tuberculosis as one of our common priorities to decrease prices and increase accessibility of treatment to tuberculosis drugs. So it is it's a high priority for the movement, and I would say as well, we need this kind of studies, we need this kind of evidence, because this fuels our lobby, this fuels our advocacy to decrease or to put pressure at the industry, at the policymakers to make prices more accessible. Thank you.
Okay, so yes, so there's a question here. Go ahead. Introduce yourself, please.
Hi, Maxime Engels, health demographer at the University of Lincoln in the UK. I've got two questions for the first presenters. They demonstrate high specificity and sensibility after the introduction of the new protocol. I was wondering if it was, if that specificity and sensibility was constant across study site and also population type. And my second question was about their interrupted time analysis. We see that there is a lot of variability of the treatment, TB treatment initiation. I'm just interested to know more about what can explain this variability across time after the introduction of that protocol. Thank you.
So maybe I'll answer the first one for Helena about the specificity and sensitivity, and it did that vary across the different groups. Those results are interim results at this stage. We're still completing the final outcome. So the gold standard that we're comparing to is a composite standard, so it takes into account clinical contact, radiological testing, but also response to treatment. And we have 3 independent reviewers reviewing any cases to be able to designate a final outcome of definitely TB or likely TB and unlikely TB. So we haven't completed that yet, and we haven't stratified by groups, but the majority of children in the study were severely malnourished because they came from 2 sites that were nutrition centres, so it's not sure that we'll be able to see that difference, but we'll come to that. Emily, did you want to address the second part?
Yeah, sure. Thank you for your question on the interrupted time series analysis. It is true that month over month there were some jumps in the proportion of children started on treatment, and we think there can be, several factors relating to that. One thing that we know could be affecting it is the presence or absence of peak malnutrition season, but we did take that into account in the model, and we saw that overall there still was an increase after introducing the algorithms, and the malnutrition did not have a significant effect in the model. But another thing that we know that's happening in the study sites is these are real places with real staff and real teams facing different challenges, and some of those challenges are sometimes the staff who's the focal person for treating tuberculosis or for the algorithms may have to travel or go on holiday, and we actually saw that sometimes when this happened, the proportion of children started on TB treatment dropped. So that just reinforces to us the importance of actually implementing these algorithms as a programmatic level that everyone providing care in the projects feels responsible for, and that it's really important to integrate TB diagnosis at all levels across the projects.
Thank you, Emily. Over here.
Hello,
Chris.
my name is Christopher. I work with MSF in Paris. So 2 questions. First one is for Gino regarding access to therapy for post-tuberculosis patients. In your experience in the 3 settings, were there actually sites or instances where patients could actually get access to post-TB therapy, especially when they have obstructive and or problems with respiration? The second question is for Helena and Emily. It's similar to the first question that was asked concerning malnourished patients, specifically in places where there is no access to X-ray. Have you had any issues regarding, I would say, over-inclusion of patients based on that algorithm? Thank you.
Go ahead, Gino.
Okay.
Thank you for your question. Yes, it's a very good question, and it's a key question. The fact that what we can propose to those who are facing PTLDs currently in our country, in Africa, and the response is finally nothing. Nothing. The first problem is the caregivers. The recognition of PTLD by the caregivers is very low. They have very few caregivers today who can say that these guys are suffering from PTLDs. Most of the time, patients, when they are complaining for PTLD, they are just assimilated like a recurrence of tuberculosis, or they are continue to have some symptoms from tuberculosis. Many times they are treated again for tuberculosis wrongly. So finally, in Africa, you will see those type of patients who come back many times and without any solution. But since I can say 2 years now, there are some countries like in Uganda, in Malawi, and recently also in Tanzania. The National TB program tried to propose a post-TB care with mainly a rehabilitation program to try to have a solution for those type of people. But the main problem is the recognition of PTLDs by authorities, by international authorities, and beginning by the WHO, for example, and to try to put some effort to bring a solution to those patients. Yeah.
Thank you, Gino, and we can apply that to MSF also, I think. Yes. Go ahead, Emily, with the second question.
Yeah, thank you so much for the question around the use of the algorithms in populations with a high proportion of children who are malnourished. And to answer your question of whether the algorithms were used in such settings, even without access to X-ray, yes, this was true because in Nigeria and Niger, where we have a high proportion of children with malnutrition, it wasn't possible to provide an X-ray to each and every child every time, just due to the high volume of patients. So we did take this into account. And there were a lot of discussions around this issue of, are we over-treating children in these settings? And the teams really had to talk about it a lot, and they came up with some different solutions because the algorithm also does allow for clinical judgment. So the clinicians were able to take this into account when dealing with malnourished populations, and in certain settings, like in Nigeria, they were able to wait 2 or 3 days and to see how the child responded to other treatments before applying the algorithm score. And the results that we showed, like Kathy said, are from a proportion of children that is a very high proportion of children in this study were actually malnourished. So we feel that the sensitivity and specificity are still quite strong, even in populations with a high proportion of malnutrition. And then overall, it's important to keep in mind that generally the way the algorithms were designed was with the understanding that it's better to treat someone for tuberculosis, maybe in the case that they didn't need it, than to let a child die of tuberculosis.
Thank you, Emily. Marilyn?
Yeah. Marilyn Bonnet, IRD. Je vais parler en français. Ma question, elle est pour Lorenzo.
This is a question to Lorenzo.
Quand on a un contrôle très robuste,
one can see that your control is very high, 88% of efficacy, but the non-inferiority is 12%. So it's quite something, and you could show us that patients with severe lesions with a high bacterial count are responsible for this, and because of recurrences and late recurrences, and so that this does call into question the WHO gold standard that is that one size fits all with standardized approaches. So I'd like to get your take on this, and also maybe it is that we don't have the right sort of antibiotics and antibiotics that are sufficiently potent to truly sterilize the patients. And even when this is drug susceptible, it's very difficult to guarantee this sterilization over time. Well, there is no much choice, you see, in terms of treatment. These are the best drugs, oral drugs that are available to treat TB. So BDLC was obvious, and we don't have anything more sterilizing. And even if there are a lot of new chemical entities under scrutiny, none can be as efficient as rifampicin or fluoroquinolones. So maybe it's not the solution to look for highly sterilizing drugs. Maybe, as you said, it's better to stratify and target depending on the patients. So one size fits all, we know, isn't the best option. And some trials are now starting on this stratified and targeted approach. And we hope that endTB-Q is going to be a way to get stratified recommendations for patients. And
mentioning the pipeline that, and we have the last question about the access to expert. Expert is the test that can give us a diagnosis of TB, but also resistance to rifampicin. But we also have another cartridge called XDR that can give us results of fluoroquinolone resistance. And the question is, how can this, the fact that we can diagnose these now, how is this going to impact? I mean, the problem is that only 50% of people diagnosed with TB actually get an expert test, and very few, a handful, get an XDR test. So there's an enormous problem of access to diagnosis of resistance. And the resistance to bedaquiline, we don't have a rapid test, and the access to resistance testing for bedaquiline is very long and difficult, and the resistance is going up very, very fast. So that pipeline becomes very important to have access through compassionate use to give really patient-centered care, and those patients that don't have a treatment possible, we get access to these new experimental drugs through compassionate use. Okay, so we're going to wrap up there. Thank you very much to all the speakers for those excellent studies and presentations. Please thank them for us.